This 23-year-old female patient has a medium smile line and an adhesive bridge to replace a congenitally missing left lateral incisor in the maxilla. The adhesive bridge suffered recurrent loss of retention. Thus, it was decided to evaluate the local anatomy for an endosseous implant to allow an implant-supported single crown. The detailed view shows the Maryland bridge and the local bone deficiency in area 22 on the facial aspect. In addition, a gingival recession of about 3 millimeters is apparent at the adjacent canine, which needs to be treated as well during the same surgery. The periapical radiograph demonstrates a radiolucency in the apical area of the missing lateral incisor caused by a facial undercut. The digital volume tomography reveals the details of bone anatomy in the edentulous area. There is sufficient bone height, but a reduced crest width with a significant facial undercut, which is typical in sites with congenitally missing lateral incisors. The facial undercut is clearly visible in an occlusal view. In this situation, a triangular flap design will be used to avoid a vertical releasing incision on the mesial side of the flap and a potential scar line within the aesthetic zone. The surgery begins with an intrasulcular incision from tooth 11, which is extended to the papillary area with a number 12 blade. In the edentulous area, a mid-crestal incision is made, followed by an intrasulcular extension to the first premolar. There, a vertical releasing incision at the distal line angle is cut. The mucoperiosteal flap is carefully mobilized, first at the papillary area using a fine tissue elevator, and then in the crestal area. Next, the mucoperiosteal flap is elevated from the underlying bone with the paddle-shaped end of the PP Boozer instrument made by Hu Friedi. 2 retraction sutures are applied on the inside of the flap and attached to hemostats to ensure sufficient visibility and access to the surgical site. The debridement of the bone surface reconfirms the significant undercut on the facial aspect. Next, the root prominence of the canine is slightly reduced in volume using a fine white stone. Implant bed preparation is started with a large diamond burr to smooth the coronal part of the alveolar crest. The mirror view shows the well-scalloped bone structure in harmony with the neighboring teeth. Then a number 1 round burr is used to mark the appropriate implant position. The preliminary marking is enlarged with a number 2 round burr, giving careful attention to keep sufficient distance from both adjacent teeth. The first 2.2 millimeter spiral drill is now used in the correct direction and angulation to carry out the initial preparation of the implant bed. As expected, the drill perforates the facial bone because of the bony undercut. A 2.2 millimeter depth gauge is inserted to check the sink depth and axis of the first preparation. Then the second 2.8 millimeter spiral drill is used to widen the implant bed preparation, using copious irrigation with chilled saline. A cut-off 2.8 millimeter depth gauge is inserted to confirm the direction and sink depth. Both are appropriate for a 3.3 millimeter bone-level implant to be inserted in a correct three-dimensional position. After irrigation with sterile saline, the mirror view shows the prepared depth to be approximately 14 millimeters. A special profile drill for a 3.3 millimeter bone-level implant is used to expand the coronal part of the implant bed. The facial bone wall is less than 1 millimeter thick, whereas the intact palatal bone wall has sufficient thickness. The cortical bone surface is perforated in the peri-implant area with a small round burr to open the marrow cavity and to allow bleeding into the augmentation area. Autogenous bone chips are collected with a Hu-Friedy bone scraper from the periapical area of the implant bed. The bone chips are set aside in a sterile glass dish. The same procedure is repeated to collect additional bone grafts. Blood is collected with a syringe and also kept in a sterile dish. A fresh number 11 blade is now selected to harvest connective tissue graft from the palate. A superficial line incision is made on the palatal mucosa from the first molar to the premolar sites. In the canine area, the incision is curved towards the mid-palatal aspect to create a triangular flap. A split-thickness flap preparation goes from the initial incision towards the mid-palatal aspect. Now the connective tissue graft is cut along the initial incision. The connective tissue is then detached from the bone surface using the paddle-shaped end of the PP Boozer instrument. The attached portion of the graft is incised at the distal, medial, and mesial borders. After this incision, the connective tissue graft can be easily harvested from the donor site. The harvested graft is put on a sterile plate and moistened with saline. The clinical view shows good adaptation of the palatal flap at the donor site with the single incision technique. An EDTA gel called Pref gel is applied on the canine root to expose more collagen bundles at the root surface. After 2 minutes, copious irrigation removes the Pref gel. A 3.3 millimeter bone-level implant made by Straumann is now selected and mounted on the implant insertion device. The implant with an SL active surface is slowly inserted using a contra-angle handpiece, turning at a speed of 15 RPM without cooling. After the implant reaches the correct insertion depth, the implant insertion device is removed. The mirror view shows the fenestration defect and the level of the implant shoulder, which is positioned roughly 3 millimeters apical to the future soft tissue margin. A 2 millimeter bone-level healing cap is screwed into place. The locally harvested autogenous bone chips are applied directly onto the exposed implant surface. They will speed up new bone formation at the bone-implant interface. The combination of autografts and implants with an SL active surface has led to a general reduction of healing periods for GBR procedures in the past 2 years, since both accelerate new bone formation during initial wound healing. The applied autografts are covered with a layer of bio-os granules for contour augmentation. Small particle granules are used, as usual in aesthetic sites. Additional bio-os granules are applied at the implant site and around the canine root. A resorbable non-cross-linked collagen membrane is cut into 2 pieces, a larger and a smaller one. The larger strip is trimmed to the required shape. This membrane strip is put in place over the grafted site. The membrane extends to the canine site as well. Blood is delivered onto the membrane with a syringe. Once the membrane is soaked with blood, it becomes soft and is easily adaptable. A second, smaller membrane strip is positioned over the first layer, according to the double-layer technique, to improve the stability of both membranes. The harvested connective tissue graft is placed over the exposed root surface of the canine to cover the recession. Before the wound is closed, Emdogain is delivered onto the root surface and then covered with the graft. The flap is mobilized to confirm the tension-free status. The tension-free wound closure is begun in the distal corner of the edentulous area with an interrupted single suture. Non-resorbable 5-0 polyamide sutures are used. An additional suture is added in the mesial corner of the edentulous space. Mattress sutures are used for the papillary areas, whereas the releasing incision is closed with 6-0 single sutures. An additional 6-0 suture is applied for the soft tissue graft to enhance its stability. The donor site is primarily closed with interrupted vicryl sutures. To avoid direct compression on the surgical area, the provisional denture is adjusted. The provisional denture is now put back into the mouth. After cleaning the patient's face, a pressure dressing is applied extraorally to the upper lip to minimize post-operative swelling. The patient is instructed to apply cold packs in this area. In addition, a perioperative antibiotic coverage is given for 3 days. The soft tissue healing progressed well, but the healing of the root coverage took some time. The left picture shows the healing status at 2 weeks following surgery. It's obvious that the connective tissue graft demonstrates secondary wound healing. The right picture at 4 weeks shows the progress in soft tissue healing. At 6 weeks, soft tissue healing has further progressed. The thickness and keratinization of the mucosal margin at the canine is improving. At 8 weeks, the thickness and color of the mucosa at the canine is close to normal. The soft tissues at the implant site have healed well. The corresponding periapical radiograph shows stable peri-implant bone crest levels around the bone-level implant. The reopening is done with a punch technique, inserting a longer healing cap. The implant was restored by the referring dentist with a provisional crown to optimize soft tissue conditioning. The peri-implant soft tissues have further matured, but the shape and color of the acrylic crown are not perfect yet. The final restoration can be initiated now. The final treatment outcome, 6 months following implant surgery, is pleasing. The root coverage of the canine is successful. The periapical radiograph shows stable crest levels around the implant and minimal bone remodeling. The implant has an excellent long-term prognosis if good home care is provided. This direct comparison of the pre-operative status and the final outcome clearly shows significant improvement of the dental aesthetics.